Hello, I'm Daniel Margolis from Weill Cornell Medical College, and it's my pleasure to talk to you today in this brief video vignette on the recent publication, Quantitative Prostate MRI, in the AJR special series on quantitative imaging. These are my disclosures. As you probably know, current prostate MRI assessment is largely qualitative. The single exception is that we often assess the size of a lesion in order to ascribe a level of suspicion. This is true for PIRADS, which is used for primary cancer, as well as systems such as PIRR for treated cancer and PRECISE. Performance varies by radiologist for all of these qualitative systems. Here we see some examples from AJR publications on the positive predictive value and area under the curve characteristics for PIRADS. So there is great hope that with quantification of assessment, we can further standardize and potentially improve performance. One of the first components that shows great promise for quantification is the apparent diffusion coefficient of diffusion weighted imaging. This is a simple calculated metric, which is currently only being used in a qualitative method, but which has quantitative applications. It's widely recognized as a quantitative MRI biomarker, and it shows strong discriminatory value for clinically significant prostate cancer, as well as recurrent cancer after treatment. However, the calculated value depends on the parameters used to acquire it, and therefore the value varies markedly from publication to publication showing its use. There are also advanced diffusion techniques, including intravoxel incoherent motion deconvolution, diffusion kurtosis, and diffusion tensor imaging, which purport to have even better discriminatory value for clinically significant cancer and potentially treated cancer. There are some specific implementations, including restriction spectrum imaging. However, as these techniques become more advanced, the acquisition becomes more technically challenging. Tissue characterization includes evaluation of the inherent T1 or T2 and provides improved diagnostic value. There are also advanced tissue characterization techniques, including luminal water imaging and hybrid multidimensional imaging, where we see an example here from AJR in 2016. Dynamic contrast enhancement primarily uses a modified Tufts model to provide quantitative values, and these also have shown independent discriminatory value for detection of primary cancer and for determination of response after treatment. There are also post-processing techniques, and these range from simple metrics, including evaluation of size and shape, to radiomics, texture analysis, and even artificial intelligence, which purport to give us quantitative metrics, including a cancer probability map, as shown here. These can also be applied to the quantitative components that we've previously mentioned. So I'd like to thank you for your attention. You may have noticed there's not a slide recommending a specific metric, and this is largely related to the variation in the techniques utilized. I think in the near future, we will see a lot of standardization across centers and hopefully recommendations either from our professional societies or possibly from our vendor collaborators on standardized quantitative techniques that can be applied with the touch of a button by implementing it from the vendor application side. Thank you for your attention.